Good morning, good afternoon, good evening, ladies and gentlemen. I am Paola Berberino, the Chief Executive Officer of Alzheimer's Disease International, and I am delighted to welcome you to this symposium that we put together for you called The Right Care at the Right Time, Why Adapting Long-Term Care Matters. In a moment, I will introduce the speaker to this panel, but let me tell you why I put this panel together for you. The fifth and fourth areas of the Global Dementia Action Plan of the WHO on dementia that was approved in 2017 are some of the most complex, and they regard the treatment and care. We often speak of many of the other areas, but very rarely we have an opportunity to speak about long-term care. And I felt that this audience is the audience, and more than anyone else, will understand its significance. I've tried to put together a panel that really goes back to the issue of why national plans matter, which is what ADI is trying to do now, to transform a global plan to a national plan, where every government is taken into account and takes responsibility for doing something on the important issue of Alzheimer's and dementia. Long-term care is difficult, long-term care is costly. And so you will see how this panel is going to touch on every single one of those topics. But now, without further ado, let me introduce you our first speaker, who is a bit of a legend in his field. Professor Anders Wimo is from Sweden. He's Professor Emeritus at the Department of Neurobiology, Care Science and Society at Karolinska Institutet in Stockholm. He's also a family physician at Bergsjö in Sweden. Anders' research areas are geriatric health, economy, and epidemiology. He co-authored the Alzheimer's Disease International World Alzheimer's Report 2010 and 2015 about global dementia epidemiology and cost, and he was the principal author of ADI's 2018 report on the global estimates of informal care time. He has also contributed to a number of other ADI reports. He is a member of the steering commission also of the population-based project Swedish National Study on Aging and Care. And he's got so many other things under his belt. I'm not going to go on. He's going to talk to us about the cost of informal care, particularly as dementia becomes more complex, how this impacts the cost of care to family and to societies. Anders, the floor is yours.
Hello, everyone. Today we talk about the economic aspects of long-term care for people with dementia. And these are my disclosures. Today, there are about 55 people with dementia living in the world, and that figure will increase to almost 80 million in 2030 and almost 140 million in 2050. And as part of the WHO's project about dementia, we estimate that the global societal cost of dementia was $1.3 trillion in 2019. And of that cost, about 50% were estimated to be costs of informal care. Now, what is long-term care? Well, I think most of us think relates to long-term institutional care in nursing homes, care homes, group homes, etc. But long-term care also takes place at home by family members as informal carers, but also as formal care by staff in people's home. And if we look at the unpaid informal care at home, we estimated in the WHO project that it produces more than 130 billion hours per year. It corresponds to 67 million full-time workers. And of those, 70% are related to women, and it corresponds, as I said, about 50% of the total society costs. So in that sense, of course, particularly for women, it's good for the people with dementia, but it also, in a way, is a hinder for women to enter the labor market, also to get education. So this is a really interesting and important issue to discuss. And where do people with dementia live? Well, in high-income countries, we estimate that about a third to about 50% in different countries live in long-term institutional care. But in low and middle income countries, it's less than 10%. In many countries, it's almost 0% because there is no existing long-term institutional care in many low-income countries. And we also estimate that about 8.5 million people with dementia live in long-term institutional care in the world. And long-term care is a major cost driver, particularly in high-income countries, because the nursing home cost may vary between $50,000 per year to more than $200,000 per year in high-income countries. And in my country, the nursing home costs were about 64% of the total societal cost. So long-term institution care is a heavy cost driver. And if you look at data from OECD, which is mainly consists of rich countries in the world, you see there's a great variability also in these countries in the proportion of long-term care, institutional care costs in relation to GDP. And also, if you look at the number of beds per 1,000 people 65 plus in different countries, we have the same pattern. A great variability actually in high-income countries, from very, very, very low figures in Greece and Turkey to very high figures in Netherlands and Luxembourg. And it also is a heavy burden on the families. And these are estimates by Alzheimer Europe. And you can see there's a great variability. In many high-income countries, such as my country, Sweden, Switzerland, the out-of-pocket proportion is about 10–20%. But in many countries, there is almost 80 or perhaps 80%, or 100% that is related to out-of-pocket costs for families. So it might be a very heavy burden on families to pay for long-term institutional care. So what to do about it? Well, of course, there are hopes that disease-modifying treatment and prevention make the expected increase of people with dementia get slower. But also, there are risks with this rapid increase in numbers of people with dementia. First, of course, there will be a heavy burden on families and informal carers. And there may also be risks that we are storing people with dementia in low-staffed, cheap institutions. And to simplify, the great challenge in high-income countries is the funding of the long-term care sector, particularly the long-term institution care sector, while in lower middle-income countries, the challenge is to establish a long-term care infrastructure and its financing alongside informal care. And what are then the options and the possibilities? Well, if you looked at the welfare state paradigm, in terms of the positive income elasticity, because if you have a growth in GDP, the gross domestic product in a country, it often results in even higher investments in the welfare sector, such as healthcare and social care sector and long-term care. So we need to put more money in the system. And one is, of course, by taxes, and that's the solution in many high-income countries, particularly in Europe, in the welfare states, but there might also be insurances with different solutions, like social health insurances, which most often are compulsory. There might be very big funding for that, and they're very regulated, and they're based on solidarity. There is no risk premiums. There will be access to anyone who needs this support. There may be also community-based health insurances with local groups, voluntary and non-profit acting. But of course, there might also be private, individual, voluntary insurances, which are commercial for profit and the risk premiums. And there might also be mixed models. And then, of course, there is the pure out-of-pocket, the 100% out-of-pocket for long-term care. And for me, long-term care is an infrastructure. Of course, in the center, we have the informal carers, which are providing most of the long-term care for people with dementia actually in the world. But we also need, and this is crucial, it's not long-term care, is not simply nursing homes. It's the whole infrastructure for long-term care, including good diagnostics and medical care and treatment, of course, counseling to families, case management on an individual level, daycare activities and resources, home care by homemaids in people's home medical care, we need palliative care, we need respite care, and also, of course, we need some kinds of institutional care, but then hopefully not big-scale nursing homes. Better to have small group homes, small-scale institutional care. But also we need a dementia-friendly environment. We have examples from Netherlands now with dementia villages. And of course, we do need also a very high education to anyone that's involved in dementia care, including staff, but also the family members for people with dementia. And thanks for my collaborators here. It's Alzheimer's Disease International, it's Alzheimer's Europe, it's OECD, and also the World Health Organization. Thank you.
Anders, thank you so much for, as ever, another wonderful account of what is a very complex areas of economics, and an area that for us, ADI, is critical in engaging governments to do something. If a government doesn't understand the cost and the benefit to society of taking action, then it's very difficult that they will do anything. So thank you, Anders, and we'll hear from you later in the Q&A. Now it's my pleasure to introduce you to our second speaker, and she is Dr. Stefania Ilinca, researcher, policy analyst at the European Centre for Social Welfare Policy and Research. Stefania believes that we need to improve access to affordable and high quality care for people living with dementia and their families by prioritizing equity and fairness in all resource allocation decisions. Care and support should be available to those who most need it, rather than those who can actually afford it. And I'm sure that a lot of you would not be able to agree more. Today, Stefania will focus on the preparedness of long-term care systems in Europe and the policy movements that she has observed around this. She may also or may not add something about the gender issue. So I'll leave it to you to discover what Stefania is going to tell us in her presentation. Stefania, the floor is yours.
Good morning, everyone. My name is Stefania Ilinca, and today I would like to talk about whether long-term care systems are prepared to respond to rising prevalence of dementia and its impact. And let me come straight to the punchline. No, they are not. I will try to argue today that our understanding of the gaps and the vulnerabilities in long-term care systems is growing. We know what doesn't work and what threatens long-term care system sustainability and responsiveness. We also know with a high level of confidence what the pathway to improvement is, and we are slowly but surely charting the course forward. But while the progress we see is cause for moderate optimism, the pace of this progress is a serious cause for concern that we will not, as a global community, rise to the challenge of providing adequate care and support for growing numbers of people living with dementia and for their families. Let me start with some data. This was collected as part of the WHO Global Pulse Survey on continuity of essential health services during the COVID-19 pandemic. The survey covered 135 countries, and the results presented here are from April 2021. They show that despite some evidence of service restoration, over 1 year into the COVID-19 pandemic, substantial disruptions to essential health services persisted across the globe. But let me draw your attention to the fact that primary care, rehabilitative, palliative, and long-term care have been most heavily affected globally, with 41% of countries reporting disruptions that affect availability and access to quality services that are essential for people living with dementia. These results are worrisome as primary care and long-term care respond to most support needs for people living with dementia in our communities. But is the devastating impact of the COVID pandemic on long-term care systems really indicative of how well prepared these systems are to respond to the challenges of dementia? Well, the rapidly evolving emergency of the COVID-19 pandemic is certainly different in fundamental ways from the slow building public health crisis of dementia that we can see shaping on the horizon. But if unaddressed, the same issues that rendered long-term care systems vulnerable to and slow to respond to the pandemic will render the same systems unable to change and adapt quickly enough in order to respond to the growing prevalence of dementia. So let me try to summarize these briefly. Our health and long-term care systems remain deeply fragmented. Service plans and policies are not coordinated across sectors, across care settings, or across different levels of government. A proper system response to dementia will require a cross-sectoral and society-wide approach. But the pandemic has shown us how fragmentation feeds directly into low system responsiveness, as well as into patchy, incomplete, and unharmonized planning that left long-term care services highly vulnerable. We have also felt acutely the limitations of current care models. A reactive and a provider-centric approach to care meant long-term care systems could not adapt quickly enough to the changing situation. These are the same care models that cannot flexibly adapt to the changing and progressing needs of people with dementia, not without a complete reorientation towards person-centered care. Closely linked with this point, long-term care systems that do not value and do not invest in prevention-oriented approaches will quickly be overwhelmed by rising demand down the road. Many dementia cases are preventable. Severe symptoms and functional decline can be delayed or avoided. So every investment in primary, secondary, and tertiary prevention we make today is a saving in the future. We've also seen efforts to plan and to react constantly frustrated by a lack of relevant data and on the resources and the relevant needs. Preparedness and good planning needs a strong and integrated health and long-term care data infrastructure, and that is all but lacking in large parts of the world. Finally, and crucially, there is no care and there are no long-term care systems without a care workforce. And by this, I mean both formal and informal. I will not touch on this topic in detail as it has been covered by other interventions, but one cannot overstate the importance of investing in stable, sufficient, and a well-treated workforce. Throughout, we must keep in mind and work to minimize profound inequalities in risk exposure, health, and access to care. So let me take maybe a step back and let me be clear about what we mean when we talk about the long-term care system. Well, the WHO definition is that the long-term care system encompasses all organizations, people, and actions aiming to promote, maintain, or improve well-being, health, and functional ability for individuals with limitations in intrinsic capacity. Such actions span the boundaries between health, long-term care, and social protection systems that are represented in this diagram as partly overlapping, horizontally aligned circles. But they also span the boundary between formalized service delivery and informal care provision, represented here as the concentric circles that build up the long-term care system in the center of the image. The joint or complementary provision of formal and informal care is the determining characteristic and the core of long-term care systems, with informally provided care accounting for the vast majority of support. At the same time, enabling age or dementia-friendly and inclusive local communities and environments contribute to ensuring that people who experience declines in intrinsic capacity can still function independently for longer periods of time. Therefore, formal care services, informal care, enabling environments should be considered the three components of a long-term care system, together with primary care and with social protection systems that can support individuals and families, especially those most vulnerable. This is our line of defense. These are our support structures for people in need of care and support, including for people with dementia. But we have seen all these structures buckle under the shock of the COVID pandemic, and we have seen them struggling to cope with the pressures of an aging population. So how do we think they will fare in the face of a growing prevalence of dementia and its associated impact? Are they prepared? Well, as things stand today, as I said, there is cause for cautious optimism. We are nowhere close to a solution, but we are on a pathway to progress. Not only is there growing awareness of the changes that are direly needed, but there is also growing consensus and support about the interventions and policies that are needed to enact this change. We see building momentum for policy change at global and at regional level, and these opportunities we must capitalize on. The UN Decade for Healthy Aging recognizes as one of its 4 action areas the need to provide access to affordable and high-quality long-term care to all those who need it. and is committed to support the development of long-term care systems in every country across the globe. At European level, a EU care strategy will soon be launched, signaling the development of a common strategic vision for the development of long-term care systems, but also commitment to supporting this development with the necessary resources. ADI's own work tracking progress on the development of National Dementia Plan leads us to the same conclusion. We need to accelerate progress. At the pace we are currently moving, meaningful change will come, but will come too late for too many. Thank you very much.
Stefania, thank you very much for another incredibly interesting presentation. And I'm sure there are going to be a lot of questions for you from the floor. Now I'm going to introduce our third speaker, and she is Karen Harrison-Denning. She's the head of research and publications for Dementia UK. Karen has over 40 years experience in nursing, most of those being in dementia care in a variety of settings and of contexts. For the past 13 years, she has worked with Dementia UK, where she's now the head of research and publication. She came to the research world late in her career. She was appointed to a consultant nurse position, and the opportunity arose for a sponsored PhD. She thus gained that at University College London in 2014, focusing on advanced care planning and end-of-life care in dementia. Now, Karen is going to talk about the impact on carers and care when care become more complex, what they have to do to cope with the situations that they will face, the decision they may have to make, and how this will impact family dynamics. This is a very important issue, and I'm sure a lot of the audience will be familiar with it, but also willing to learn more about it from a specialist. So Karen, thank you for being with us. The floor is yours.
Long-term care involves a variety of services designed to meet a person's health and personal care needs over a period of time or duration of an illness. These services should help people and their families live as independently and safely as possible as their needs change and when they can no longer perform everyday activities on their own. Long-term care in the UK is provided in a different care settings and places and by different services and their caregivers, and very much dependent upon a person's needs. Most long-term care is provided at home by unpaid family carers and friends, and can also be provided in a facility such as a nursing home or in the community, for example, through domiciliary care. The most common type provided is personal care, and this involves help with activities of daily living, including bathing, dressing, grooming, using the toilet, eating, and moving around. I want to talk about the principles of long-term care across the life journey of dementia and the role Admiral Nurse case management can play in that journey. Admiral Nurses are a UK-wide model of specialist dementia nursing case management. I first want to focus a little on carer guilt. Guilt is a common feeling felt by many family carers when caring for somebody with dementia. It may be feelings of guilt for being embarrassed about the odd behaviours that the person with dementia that they care for present, or it might be about guilt in losing their temper in frustration, for wishing they did not have the responsibility of care. There is probably a very great spectrum of feelings among family and friends who make the decision about bringing carers into their home or in moving their relative to a care home. For many, there comes a deep sense of guilt or failure when the decision is made for the person to move into a care home. For many people, the image of care homes compounds their feelings that they are not doing the best by even considering a move. Many people are frightened by the very idea, especially if they remember the workhouse or long-stay geriatric hospital wards and think care homes are probably pretty similar. Others might say that in their culture, it's almost shameful to have an older family member move into a care home. Caring for somebody with dementia can force a family to make certain decisions on behalf of the person with dementia, such as stopping them from driving, or who, when in better health, they would have been fully able to make these decisions for themselves. All this can add to the feelings of guilt. People also feel guilt for reasons they don't always understand. Being a family carer may be objectively achievable for a few days, a few weeks, a few months. But family carers of people with dementia are often undertaking care and responsibilities and duties for years. Plenty of time for guilt to grow and fester. A flip side of this is that sometimes when family carers place the person with dementia into a care home, they may see that the person with dementia begins to thrive and appear better than they did before they went into the care home when under their care. And this may be because people with dementia can benefit from the routine of a care home or the additional company they provide, or simply their care now being shared across several care staff is just easier. However, such a change for the better can also engender feelings of guilt that the carer failed and was unable to achieve this at home. I just want to make a quick note also about care home staff who provide a great deal of care and support to families affected by dementia in long-term care settings. COVID-19 has changed some of society's ideas about care homes and care home workers and what they provide. While the social care sector has been arguing for many years that the system of funding for care is woefully inadequate and that this sector of care is stigmatised, it seems to have taken a pandemic to make more people appreciate that care homes and care home workers provide essential support, and that while they may be low paid, they are certainly not low skilled. A diagnosis of dementia should present the family with a care pathway where they move through care services and settings as needs arise. However, in reality, a pathway exists. If a pathway exists, it's often one that is fragmented, where families lurch from one crisis to another, often not getting the right care at the right time and in a coordinated fashion. Specific pathways can also be problematic in that needs often vary between individuals and families and over the course of time. There are certain interventions that may need to be offered consistently throughout their dementia, and others that are specific to a specific juncture or phase of their illness. We at Dementia UK mapped the interventions of Admiral nurses that they can offer against the needs that may be required by individual families affected by dementia across UK health and social care dementia wellbeing pathway, as shown here, and apologies for the complicated slide. As you see, some interventions need to be a consistent offer throughout the journey, such as advanced care planning. However, through ongoing case management and having an understanding of a family's needs, both in the present and speculating into the future, can enable a pathway that is coordinated and free from fragmentation. To counter the fragmentation of the dementia journey, Admiral Nursing has developed into a flexible and dynamic model of care to support care that can be applied to any part of the life course of dementia. It is recognised in UK policy and guidance that a tiered approach to dementia care is required through integrated health and social care systems to respond to these different levels of needs. The UK Department of Health, in collaboration with nursing organisations, developed a strategy and a vision for nursing in response to the call for integrated care in identifying appropriate levels of knowledge and skills to meet the different levels of need. However, nursing cannot nor should work in isolation, but be one component of an integrated team. More recently, NICE guidance in reviewing the evidence base for dementia care recommended that dementia care requires a collective response through an identified care coordinator or care manager. Now, evidence for case management in the UK is still rather small and inconclusive, so NICE made a research recommendation to further our understanding of case management approach in dementia care. And this was largely born out of the research findings from Dutch models of practice, and in particular, health economic evaluation by Vroom and McNeil et al. Dementia UK further developed the tiered approach to dementia care and adapted it to case management to act as a conduit towards an integrated approach to dementia care in community setting. And key to the model of admiral nursing is to be able to target support and interventions in an appropriate level of need, but also in mobilising other services within any locality to meet lower levels of need, and also to support the integrated system that continues to be sensitive to changing need and adjust their continued collective response accordingly. Whilst we would argue that an admiral nursing service is ideally based within primary care, they are often commissioned in a localised or ad hoc fashion. So we've adapted such algorithms, as you see on the screen now, almost like a form of logic model, to give a visual schema for what can be achieved and how. This here relates to one such application of the admiral nursing model to support care homes. Dementia UK established a programme of evaluation in 2014. We called it GENES, Getting Evidence into Admiral Nursing Services. Our aim was to develop the evidence base for admiral nursing through robust service evaluation, update our electronic record keeping system to support systematic collation and analysis of clinical data to demonstrate individual and collective outcomes of the intervention. Through this work, we can now demonstrate many positive outcomes for both the person with dementia and their family carers and supporters. Thank you for listening for my brief presentation. These are some of the references that have been used to guide it, and I'm happy to take questions in the plenary.
Karen, thank you so much for such an important presentation on one of the hardest and most difficult topics that a lot of our community and families have to face. Thank you ever so much for these wonderful words. It is now my pleasure to introduce you to one of my colleagues, Wendy Widener. Wendy Widener is the head of research and publications at ADI. As a research and policy project lead, Wendy leads on ADI's participation in the STRIDE, Strengthening Responses to Dementia in Developing Countries project in partnership with the London School of Economics and Political Science, the LSE in London. She has been working with several university partners and Alzheimer's Association in many countries and many continents. Her role also includes being the focal point for ADI's research connections, and especially the medical and scientific advisory panel of ADI. Wendy will now focus in liaising all of this presentation together, knitting them together and explaining why in this particular case, this area particularly matters for us and what is the ADI is doing as an organization in this particular area to sensitize governments in policy setting. So Wendy, it's with great expectation that I'm waiting to hear what you're going to talk about, and I hand over the floor to you. Over to you, Wendy.
Hi, my name is Wendy Widener. I'm head of research and publications at Alzheimer's Disease International. I'm very happy to be here today to talk to the IAGG, and thank you to the conference organizers for inviting us to talk on this symposium. And I'll be talking about complex care and dementia and why policy matters. So my colleagues that have already spoken today have already set the scene for me. And you will have seen that we know numbers of people living with dementia are on the increase, and significantly, we know that costs are on the increase. I know Anders will have mentioned that costs are increasing quite a bit across the globe for dementia. And we know that as care becomes more complex, costs increase as well. So I just wanted to share a little bit about Alzheimer's Disease International, so you know a little bit about us. We've been around for about 38 years now. We're the umbrella organization for all Alzheimer and dementia associations around the world. We have 105 members, and we have 20 that are in development. We're really the organization that represents our members at global organizations such as WHO, the UN, and also at regional bodies such as PAHO, ASEAN, that kind of thing. We're known as the promoter of World Alzheimer's Month, which happens every September. And we also publish as well, and we publish a yearly World Alzheimer report, which this year is going to be on post-diagnostic care. So for us, what's quite important is knowing about risk reduction and facilitating research about care and cure. But today I'm going to be talking about care. And I want to roll back a little bit to the World Alzheimer report that we did in 2016. And this was really around looking at care management and complex care. And it was looking at primary care and managing dementia care globally. And it was the first time that we introduced the idea of task shifting and task sharing. And what this was really about was thinking about how can we integrate care in primary care? How can we integrate across health and long-term care to make sure that we have continuous care for people who have dementia, and that we're looking at them in a person-centered way, in a holistic way, so that we're treating the whole person and not just the separate issues, separate health conditions that they have. And what this really talked about was developing a care pathway and case management strategy that enabled somebody to be followed all the way along their journey through dementia. And what this did was talk about how you could organize that in primary care that would help scale up dementia care without overburdening specialist care, geriatrics, neurologists, et cetera, so that those people could be accessed when they're for specific interventions, so that the real management of care was in primary care. And this was arguing that this sort of task shifted way of working could help scale up dementia care and make it more affordable, and also increase and improve efficiencies and avoid those unnecessary admissions to care or to hospital. And it also called for more research into advanced care planning and palliative care approaches, which I know we've talked about today as well. So what this led up to, and after about 10 years of advocating from Alzheimer's Disease International, was the Global Action Plan on Dementia. In 2017, the World Health Assembly, all of the member states ratified the Global Action Plan on Dementia, and they agreed that by 2025, 75% of the member states would have a national action plan on dementia. And it would cover these 7 areas that you see on the screen, really providing this sort of framework that would enable best care for people living with dementia, along with research and information systems. And what ADI started doing at that time was keeping track of how we were doing in terms of whether or not we were having national plans globally. And this, we started to publish on a yearly basis the From Plan to Impact report. And you see here the cover of our From Plan to Impact report number 5. And this is coming out in just a few days. I'm recording this in May. And so we're going to launch it at the World Health Assembly just this week. And it is a tally on how many plans there are globally. And I'm going to talk about that in a minute. But I wanted to also talk about why national dementia plans are so important. It's because they really are the best strategic planning tool that a government has to create that care pathway that I was talking about earlier, to enable people to have a timely diagnosis and provide that very good post-diagnostic support for people living with dementia, and also supporting their carers. But equally, it's about raising awareness so that we are reducing risk, but also combating stigma, of which there is so much when it comes to dementia. And also about measuring and tracking the prevalence and incidence and preparing for pharmaceutical breakthroughs. So back to that From Plan to Impact report, just to show you where we are now in 2022, the red countries that you see on this map are where there are national dementia plans. The gray countries are where there are plans in development, but the pink countries do not have a national dementia plan. And so you see there are whole swathes of Africa and in the Middle East and parts of Asia where we do not have, in South America, we don't have a national dementia plan. And this is imperative that we advocate and work with governments to enable them to put those in place. You can see here, this is the latest data on how many plans there are. Currently, there are 39 national plans that have been adopted by member states, 3 of which are actually integrated into other policy areas such as mental health or NCDs. There are 21 in development, but a shocking 134 member states do not have a national dementia plan. So in response to this, ADI put together from November of last year our What's Your Plan campaign. And we officially launched this to really galvanize partners to work together to develop and to fund and to implement those national dementia plans. And it's really building around the momentum from Plan to Impact 5 report. And so what we do is we work alongside our member associations in their countries to make direct contact with ministers of health, ministers of social care, ministers of finance, to start to talk about how we can bring their attention back to the commitment that they made in 2017 for that global action plan. And then we organize meetings with those ministers to help them and support them to develop those plans. And so far, we're already working with 40 nations. It's been very exciting actually to see the response. I think ministers really want to do something, but they just need to know how they can go about setting out that plan. And so we've had some really great responses. As you can see, we've met with ministers of health in Botswana, Panama, Cameroon, and St. Lucia. And we've been also discussing with other countries as well. So we're hoping that this 40 nations will increase dramatically in the next 6 months. So I wanted to just finish up and talk about what you can do, because as clinicians, you are leaders in your community and people look to you. You can help us. You can tell us what the realities are of dementia care in the communities where you work. You can tell us what the key gaps are, but also what the areas of best practice are. And so I would encourage you, in fact, I would call for you to work with ADI members in your country and help us advocate for that change. We're trying to build coalitions of stakeholders that are working in the country where you live. And we want you to join those coalitions working to advance the cause of dementia. NGOs, people in civil servants, researchers from universities, and policymakers from government. So we're calling on you to be a champion and an influencer for our cause in dementia, and help us to sort of maintain that high profile and bring attention to important dementia care interventions in your country by providing that leadership and influence across all of those diverse groups that I've mentioned. Thank you so much for having us here to speak to you, and I look forward to the question and discussion after this session. Thank you again.
Wendy, thank you very much for your wonderful presentation. It's been a pleasure to hear you stress the importance and the link between all of these important points about long-term care and what is the ADI is doing in terms of sensitizing government in this very complex area. You'll hear me talk more about it also in my own keynote presentation at other points in this conference. Now that we have heard from all of our speakers, is going to be an opportunity to open the floor to a question and answers from you, the public. And I'm looking forward to hearing what your reflections have been during our presentation and conversation. Thank you very much. And in a moment, we'll open the Q&A. Have to unmute. So good evening, good afternoon, good morning, ladies and gentlemen. It's me again, welcoming you to this session's Q&A. As you can see, we are all in very different clothes. That means that we are now live, whilst before we were recorded. Last night, you heard me speak about the national plans for dementia and why they're so important. And you heard me asking you, the gerontology and geriatrics community, joining us in our effort to sensitize governments. I do thank the many of you that have reached out this morning to me, especially through social media. It means that you are there, you are listening, and you are interested in what we are doing. Today, for this symposium, I'm joined by some extraordinary speakers, and you have just heard them all tell you their piece. One of our speakers cannot join us for the Q&A, that's Karen, but Wendy Widener has kindly agreed to answer her questions. So I am very much hoping now that we will have some feedback from you and some question in the chat. I will leave you a few minutes to compose your thoughts. But in the meantime, as I cannot see any questions in the chat quite yet, and I apologize this session in English, I know for some of you that will not be the first language. I would like to ask Stefania first about her presentation. Stefania, in your presentation, you tell us that there is hope at the end of the tunnel. A lot of our audience today, the conference is held in Argentina, will be wondering about their area of the world. So what is your view about if we do have really hope at the end of the tunnel in the Cono Sur, in Uruguay, in Argentina, in Paraguay? I'll leave that to you.
Thank you very much, Paula, and good afternoon to everyone. It's a hard question. I'm an optimist, so I see hope everywhere. And the last 2 years, I think, unfortunately, because of the pandemic, but at the very least, there is a silver lining to it, that the topic of long-term care and the topic of how we respond to the needs of an aging population has skyrocketed on the global agenda for health and for development more generally. I see so much more exchange, so much more interest to exchange experiences, to learn from each other, and slowly, but hopefully surely, there's more and more financial commitment behind it, because eventually that's going to tilt the balance or not. So I really do hope that for parts of the world where long-term care systems and health systems are still somewhat underdeveloped with respect to Western Europe or North America, there is now an opportunity to hit the ground running and to really accelerate progress. In my own country, in Romania, we're making leaps and strides in the past years in terms of commitment, of strategizing, of even committing resources, much more so than I've seen in the last 20 years. And this gives me very, it encourages me, it gives me great hope.
Thank you so much, Stefania. I continue to think that this is an effect of more people mobilizing, more citizens effectively telling their governments that they need to do something about it. But as we know, governments are very reluctant to do anything about it unless they have facts and figures. And Anders, this is where I'm bringing you in the conversation. So you have had now a decade and more of studying the cost and the economics of the social care that is clearly the biggest issue around dementia. Now, from your point of view, and you work with us at ADI for many, many years, but also with so many organizations, do you see your facts, your figures, your costs coming into government thinking, for example, in Sweden, but also beyond that? Anders, over to you. You need to unmute.
Thank you, Paula. Of course, this is a very interesting question. If you first look at my own country, Sweden, there has been a growing awareness of dementia as a great challenge for social planning, and particularly discussions about the funding of long-term care. But I think for policymaking issues, I think actually the prevalence issue is the first thing to point out. Look at the figures. What can we expect in increase in numbers of people with dementia in each country in the world? And as we know from the facts that the greatest increase will occur in low and middle income countries, not in high income countries, actually. So I think that's the first thing to point out, the increasing number of people with dementia in all countries. Then, of course, we have a very great imbalances how long-term care is funded and organized in different parts of the world. And the problem is also we need more facts, because we are rather good figures about what are the long-term care resources in high-income countries. But we know very, very little about it in low and middle-income countries. We know that there are very few such resources. We know that, but we don't know are 90% or 95% or 99% of people with dementia living at home or not. We don't know that actually in a way. We also know that there are imbalances between rural areas and urban areas in low-income countries as well as now. But we need much more facts. What is the current situation for people with dementia in different parts of the world? And we're now planning a project actually about this issue to map the long-term care in all countries in the world in a very humble way.
And Anders, I'm sure that when you map that, that will be incredibly important tools in the hands of people like us that advocate to governments to make some change. And, you know, what Stefania was saying is so uplifting that in our country, a European country, there's been a lot of progress made. Progress is possible. We know that. Yesterday, Wendy and I were poring over a letter of a low-income country, which actually is making great strides around developing an education program for nurses, and that's in Africa. And we were delighted after a few years of advocacy that is happening. But we have a really interesting question here that has come from the public, from Eduardo, who is asking us, what do we know about dementia villages, positive examples? Now, Eduardo, we published the report in 2020 called Design, Dignity and Dementia. Is a World Alzheimer report, and I'll send you the link as soon as Wendy will start telling you a little bit more about that. I know that Karen is in the waiting room. She's waiting to join us, and I will put the same question to Karen after I put it to Wendy. Wendy, tell us a bit more about dementia villages and why they're such a positive model.
Thanks for that question. And I would encourage you to look at our World Alzheimer report because it really goes into depth and several villages in several different countries. And the approach is different in different countries, you know, and that has to do with different cultures, et cetera. But we all know about some of the villages that create these open spaces for individuals to live their lives and move from spaces where their dementia is quite mild and progress to where they have more progressed dementia and get more support. And it's almost a seamless movement. This is really important. And I see that Paula has put the link into the chat, but I don't know where all of you can see it. So I'll make sure to provide it to the organizers of the conference.
Whilst we're waiting for Karen to join, I'll add that there are some wonderful examples in the report. For example, it explains very clearly how a dementia village per se is not as effective when it's isolated. A lot of importance is given to community building. So, for example, when you have a dementia village whose border, if you wish, is porous, for example, you can have a cafe or a restaurant where people in the surrounding area can come. And therefore, there is real interaction. You're not just talking of a virtual space. You're talking of a real space where people are integrated in their community. The best examples, as we know, have been deployed in the Netherlands, but nowadays the model is really all over the world. There are some wonderful examples in the report of amazing places, and you think, you know, if I ever am going to go to a care home, that's exactly where I would want to be. They're such beautiful places. Recently, we were talking with an organization in Australia about how they provide common kitchen and cooking spaces and how this really maintains a certain level of brain plasticity and activity in residents until very, very late stages. It's very hopeful. What I really would like to emphasize here, and the reason why we did this, this symposium, is that there is still a lot of ignorance about the fantastic research that is made in care. I find the governments find research into basic science and pharmaceutical science way sexier than the research in care. The research in care has made amazing steps. It's just a shame that those steps are not adopted by governments with the same level of enthusiasm and at the same kind of rate. So if any of you is interested in this topic, plenty of excellent examples again on our website under different areas. And if you want to reach out and have any questions, we can point you out in the right direction. As I said yesterday, we are all present on Twitter, on LinkedIn. Even if you don't have our emails, you can find us quite easily by typing our names. Now, I can see that there is no other question for us. So there is no point in us continuing this conversation. Probably we have overwhelmed you with information, and I don't want you to feel that we are overdoing it. I'm sure a lot of you, like yesterday night, will then reach out separately once all this information has had a chance to settle. So with that, I would like to thank my lovely panelists, Anders Vimo, Stefania Ilinta, Wendy Weidner, and Karen, of course, that couldn't be with us, but has tried. I know she's still waiting to get in. And I would, as well as thanking the panelists, thank Jose Ricardo Jaregui, who, of course, is the chair of the IAGG and has invited me to this conference and to hold this panel. Thank you very much for allowing us to sensitize a community of global gerontologists and geriatricians that we really do need to reach out to. So with that, I close the session, and I wish you all a very happy morning, I think, not afternoon, like in our case. Goodbye.